Now, by the end of the cardiac tube formation, we will immediately talk today about the septation of the heart itself. However, let me remind you of the last week's lecture. The heart was a tube. This tube has arterial end superiorly and inferiorly, caudally the venous end, cranial end arterial, and venous end inferiorly. Now the heart itself has these parts, which are the sinus venosus, atrium, ventricles, bulbus cordis, and truncus arteriosus. Now you need to memorize the names of these five parts, as they are very important as we proceed. Now the arterial end and the venous end both are fixed for a while. Now don't you forget that the part of this tube that is inside the pericardium is just the bulbus cordis and ventricle. And what does this mean? It means that no space, no much space for them to grow. And what happens here is that this is the pericardial sac. So all of a sudden these two parts, this one and this one, they would grow faster than others, than this one, than atria here. So as you can see, they would grow faster in a limited space, and therefore if any tube, you put any tube in a limited space, this tube would certainly coil, and this is exactly what would take place. These two, they would coil, growing, and they would coil, making the what we call the U shape. And what is the meaning behind this folding? This part, which was superior, has become near to this part. So this part was superior, bulbus cordis, now superior to the ventricles. Now the bulbus cordis became near to the ventricles. This is the idea behind looping, what was superior becoming near to the of course the ventricles. Now at the same time, the lower part, which is the atrium and the sinus venosus here, they would be released. They were attached, they would be released. They have two options: to go up anteriorly this way, or posteriorly. Now the coiling is not only growing to the right, shifting the heart to the left, but also anteriorly. So this room is filled by the bulbus cordis and the ventricles anteriorly, and therefore the only option for the sinus venosus and the atria is to go behind the arterial end, and that's exactly what would happen. And that's why in the normal heart, adult heart, you would see that the atria certainly behind the ventricles. Once this takes place, the shape now is said to be S, the heart similar to English letter S. Now this leaves us with this picture here at atrial end, at arterial end, sorry, and the venous end here. Okay, the atrium are there, and these are the ventricles. Then the atria would of course expand, and the ventricles also would expand, but until now the blood is coming from sinus venosus towards the atria, ventricles, and from the ventricles to bulbus cordis, from bulbus cordis to truncus arteriosus. This is the way the blood flows inside the cardiac tube. What does this mean? It means that the tube until now is not separated. So we have common ventricle, we have common atria, and we need to separate them. And this lecture, it's all about septation of the heart, which lasts about 10 days. No major changes occur in the external appearance of the heart. So what's going on is inside the cardiac tube until now. The formation of the various cardiac septa occurs more or less simultaneously. The interventricular septum, the interatrial septum, they occur at the same time, though they may last longer, especially the interventricular one to be established. Now let's begin from this. In this diagram you need to just orient yourself. This is the article, the auricle, I mean the atria, which is still common atrium. It is superior and behind the ventricles, of course, as a result of the folding, and you need also to know what is this opening. So if you put your finger inside this opening, where your finger would be, it would go to the atria. Now the blood flows from the sinus venosus to the atria, and it comes from this foramen to the ventricles, and that's why this foramen has been called Atrioventricular foramen. Atrioventricular foramen, which is a canal. In fact, it is a tube. It is not separated. There is no any separation between the atria and the ventricles. They are continuous tube until now. So we took a cross section, and you need to understand because of the looping, the bulbus cordis and the ventricles are almost in the same plane, near to each other, as we mentioned, and this is the atrioventricular canal, or this opening. It's the atrioventricular canal. As the heart tube develops, it eventually pulls the atrioventricular canal and cushion from the left to medial, as seen in the illustration. If you just appreciate this fact, look at the atrioventricular canal. It was to the left. Now it is almost to the middle. So the position of this canal as the heart develops, it would be shifted from left to mid line. So this is what we call alignment between the atria and the ventricles, and this is very important. You need certainly to appreciate the blood flow, you need to know that this is uh, the ventricles, and what is between them here, the primary interventricular foramen. They are continuous with each other, but what I can see behind this is the atrioventricular canal, which has been became in the middle. Now the atrioventricular canal has this ventral and this one here dorsal cushions. In some textbook they call them superior, inferior, and both lateral there and there. As you can see, lateral cushion here, right lateral cushion, left lateral cushion, and of course this would be the superior here, and this would be the inferior, or as you can see, dorsal, ventral, because they are in a plane where anterior and posterior. It doesn't matter. For endocardial cushions, they would form two canals. How they gonna do this? First, it has a round opening, as we mentioned just minutes ago. Then it becomes a transverse, as you see in this. First it is circular, then with the growth of endocardial cushion, the superior, inferior, lateral, it becomes transverse, and then of course the inferior cardinal and superior cardinal cushions, they fuse, and what we would have right and left atrioventricular canals rather than one only. This is a simple way to transform a canal into two canals, to transform a circle into two circle. What would you build? You would build a septum between the superior and inferior borders of course this circle, and this has been achieved by the help of endocardial cushions, the dorsal inferior, the ventral and the dorsal or superior and inferior, lateral right and left cushions, as they form this septum. Now this septum, now we have right and left atrioventricular canals, as you can see. This is one canal, this is another canal. The ventricles are still common ventricles, the atria are still common atria. Now, so the septation here, this canal is very limited to this area, and now the atria and the ventricles, they are separated only by this atrioventricular septum, partially of course, and this is another cross section. This was the canal. The blood flows from the sinus venosus to the atrium to the ventricles through atrioventricular canal. Now the endocardial cushions, they grow, and we took a cross section here. You can see this. Now this is to thickening the atrioventricular or endocardial cushion appear on its dorsal and ventral walls, as we mentioned. They grow towards each other and fuse, forming the septum intermedium, thus dividing the canal into right and left halves. Okay, this is the newly formed septum. We call it septum intermedium, by the end, this would be the septum intermedium, separating the atrioventricular canal into right and left canals, separating partially the atria from the ventricles, and establishing a pillar inside the cardiac tube that can easily communicate with the atria, communicate with the ventricles. Now, this is also something interesting to talk about. As the canal becoming smaller and smaller in terms of each canal, I mean, two canals, the blood would begin to flow through these two canals, and the boundaries of each canal here is still made out of endocardial cushions, and as the blood flows through the endocardial cushions here, it would sculpture the valves, the cusps, the chorda tendini, and the papillary muscles. Now, what is important is this: you need to understand that the heart is this area, the endocardial cushions. They develop from the neural crest. We did mention the neural crest, and I'm sure that you would appreciate the fact that neural crest cells, they're migrating anterocranially cranially to reach the heart, so they are not originating from the cardiac cells. They are rather invading the heart, and sometimes especially in early stages of development, these cells, the neural crest cells, may be arrested during their migration due to many different reasons: radiation, infection, drugs, we don't know, and as a result they wouldn't reach the heart, and therefore the septum primum wouldn't be complete. All the derivatives of endocardial cushions and all their contribution would be questioned as we proceed. I would talk about this in details. So let me just remind you that we had a common atrioventricular canal that has been to the right, then it became to shift towards the midline alignment. Then this canal has been separated into two by the aid of endocardial cushions, which are originating from neural crests, and then the newly established septum has been given the name septum intermedium. This one here, it separates the atrioventricular canal into two right and left canals. It also partially separates the atria from the ventricles. And as the blood flows through these canals, and it sculptures the related valves and their chorda tendini, plus cusps and papillary muscles, and we did mention this earlier. Now let's talk about the atrial septation. Now, before we proceed into the atrial septation, let me just remind you that until now the heart is acting as one pump. I mean, it is not as in adults. We have two parts of the heart. The right pumps to the lung, lungs, and the left pumps the blood towards the body. What we have here in the embryo, common chambers, they are opened into each other. They communicate with each other. The atria, the ventricles, they communicate freely with each other, and they both also communicate with each other. The blood comes from the atria, flows into the ventricles, and in fact the embryo is not getting affected by this, since hence the blood is coming oxygenated from the maternal site, which is the placenta, and goes also to the placenta. The lungs are not functioning, and therefore the heart has a very simple function, just to pump what comes in it outside of it. And this is perfect for the embryo. Now we need to think about after birth. After birth, this can't be happening. We need the heart to be formed into its final shape. Two chambers, the right chambers and the left chambers, as we need to separate the deoxygenated blood from the oxygenated blood. But until now, still the embryo has a common atria, common ventricles that freely communicate with each other. So if we what we gonna do now, it is something for the future, not as a necessity for the embryo itself. Therefore, let's talk about this challenge. The blood coming from the inferior vena cava towards the right atrium. This is the atria, the left atrium. This is the right atrium, and the blood easily coming from the inferior vena cava towards the, of course, towards the right atrium. There is no need for this oxygenated blood to go to the right ventricle, and from the right ventricle through pulmonary trunk to the lungs. Hence the lungs themselves are not functioning, and therefore and on top of everything, the blood itself is oxygenated. There is no way it's gonna go to the right ventricle and then to the pulmonary trunk and finally to non-functioning lungs, because there is no need for this to happen. And therefore there would be a shunt of blood from the right atrium towards the left atrium. In fact, I did mention that the atria until now they are common atrium. So what comes in the right goes to the left, and we need to separate it just for the after birth life, not for the intraembryonic life. And the challenge is, if we separate the left atrium from the right atrium by building a septum, we would stop the blood flow from the right atrium towards the left atrium. But again, if we leave it for after birth, the newly born baby would suffer from mixing of oxygenated and deoxygenated blood. Now, and this is a challenge, how to build a wall between two atria without cutting off the blood supply to the embryo, bearing in your mind that you need this septa for after birth. And in the next couple of slides I would try my best to answer this question. The question is very simple. If you leave it, leave the blood coming from the right going to the left, this wouldn't harm the embryo, but it would harm the embryo after the baby after birth. If you to build the septum, immediately you would cut off the blood, the embryo would die. So how would you get this job done? As you know, the septum primum, which is we will build, but before we proceed, let me just remind you that we have this septum here. This septum, we call it septum intermedium. So if you to build any septum, interatrial septum, you would certainly try to reach this septum intermedium. And also it is true for the interventricular septum. You would try to reach this central pillar, as we call it. So what would happen here, that during development a sickle-shaped or a crescent-shaped septum appears from the roof of the primitive atrium or the common atrium. As you can see, this is the septum, and we call it septum primum. What we call it? Septum primum, because it's the first one to appear. Now septum primum has a job to close off this area between the two atria and to reach the septum intermedium. It has this shape like crescent shape, and it is going from superior to inferior, and from posterior to anterior, until it reaches the septum intermedium. Now we call it septum primum. This is septum intermedium, which we are streaming for, and this is septum primum. What we're gonna call this gap between the newly formed septum primum and between septum intermedium, this opening we call it of course foramen primum, as you can see. So it is the gap between the septum primum as it forms and the septum intermedium, and this is, we call it septum foramen primum. So again, the atria, the left and right, they were common atria with one cavity. All of a sudden a septum appears from the roof of this common atria. It looks like crescent in shape. It is crescent in shape. Begins to close off, separate between the left and right atrium, okay, and to reach the septum intermedium. The gap between them, we call it foramen primum. The blood would still be able to flow from the right atrium towards the left atrium through this foramen primum. Now if you to close this septum, you would cut off the blood from the right atrium to the left atrium, and certainly the embryo would die. And therefore, before this event takes place, which event? Before this, the final adherent of the septum primum to the septum intermedium here, okay, as the foramen primum gets smaller and smaller, another foramen called foramen secundum began to appear in the superior part of septum primum. So we had here septum primum, and we had also here foramen primum. Now, as septum primum approaches the septum intermedium, the foramen gets smaller. Foramen primum gets smaller and smaller and smaller until it reaches a very small size. At the same time, programmed death of cells would begin where? In the superior part of the septum primum. So as you can see, septum primum is related to two foramina. Foramen primum, which is the gap between the septum intermedium and the growing septum primum, and foramen secundum, which is nothing but programmed cell death inside the upper part of septum primum. So two foramina related to septum primum. Now, eventually, foramen primum would be closed as the septum primum gets attached to the septum intermedium, and the blood now flows from the left right atrium through the foramen secundum to the left atrium. So if you to elaborate on this, one can think what we are doing. We just we didn't close off we didn't build a septum between the two atria. We left foramen secundum, but in fact you have to think about it that we already built a septum and we left a foramen for the blood to be shunted from right to left. So we've done something good, but we need now for the afterbirth to think how we're gonna close this foramen, and therefore another genius design here to be witnessed. All of a sudden, septum secundum grows from the ventrocranial wall of the atrium immediately to the right of septum primum. So this is septum primum, let me indicate it, with a foramen secundum in its upper part here established. Now all of a sudden to the right of the septum primum, septum secundum begin to grow. Now the lower edge of the septum secundum is thick and firm. This one here is thick and firm. It gradually overlaps the foramen secundum in the septum primum. So the job of this septum secundum is to overlap this opening. The septum secundum does not reach, so the septum secundum would not be attached firmly to the septum intermedium. So the septum primum does or did that. Septum secundum won't reach the intermediate septum because it has a different function. Its main function to overlap the foramen secundum. Now the blood here is we have two septum, the septum secundum and septum primum. Inside septum primum we have foramen secundum, and of course septum secundum would leave this opening here. We call it foramen ovale. Now one of them, they are different from each other. The foramen ovale is related to the septum secundum, and foramen secundum is related to septum primum. Foramen secundum is on the superior part of the septum primum, and foramen ovale here Now in this diagram you would see that the blood is coming from the right atrium through the inferior vena cava towards the newly formed foramen ovale in the septum secundum. It would be shunted towards the foramen secundum inside the septum primum. So what is the difference between foramen secundum and foramen ovale? Foramen ovale is near the floor of the atrium, while the foramen secundum is near the more to the superior part of the atrium. Now, the opening between the septum secundum and the septum primum is called foramen ovale. As you can see it in this section, this is septum secundum. It has a foramen here, entrance, and we have here of course, foramen secundum. So the blood goes from this foramen within the septum secundum to flow into the left ventricle through foramen secundum. We call all this foramen ovale. We call all this foramen ovale. It's rather like blood flows from one opening to another opening. And the question is why we doing this? Why we are building this septum secundum? Why we need it? We need it for the after birth. Okay. Now let's go back to septum primum. Septum primum. Now the cranial part of septum primum gradually disappears. This part disappears. We have no problem with it to disappear because we build another septum here, septum secundum. Now the remaining part of the septum here attached to the endocardial cushions forms the valve of oval foramen. Now you would imagine this part is like a flap. When the blood with the pressure comes inside the embryo here, it would go and be in the left atrium. Now the lower edge of septum secundum is thick and firm. In contrast, the edge of the septum primum that forms the lower boundary of the foramen secundum is thin and mobile like a flap. So this is the flap of the septum primum, and this is of course the part of the secundum. This what is related to septum secundum is rigid, tough part. Here we have a flap more flexible from the first from septum primum. When blood tends to flow from the right ventricle towards the left, from the right atrium towards left atrium, this thin flap moves away and there is no obstruction to blood flow. So this is characterized by mobility. It's not rigid. Blood pressure can easily push it towards the left atrium and the blood would flow. However, when there is a tendency for blood to flow from left to right, so if the blood wants to go back from the left atrium towards the right atrium, the blood itself would push this flap against septum secundum and it would the foramen ovale would be closed. So that's why we call it like a valve, foramen with a valve. This is now after birth, and this is the answer to all our questions. When lung circulation begins and pressure in the left atrium increases, the valve of the oval foramen is pressed. We mean this. The valve of foramen ovale, we mean this. As the pressure increases here with the lungs taking their function, of course the pressure would increase, and this would force the valve of the foramen ovale, which is part of the septum primum, to close off the foramen. Against the septum secundum, obliterating the oval foramen and separating the right and left atria. Now, so after birth, we would have these structures. Most of you have seen them in the lab. After today's lecture, you just need to know their embryological origin. Annulus ovalis represents the lower free edge of septum secundum. That edge, which is a firm edge of septum secundum, and of course here it is, here, and the limbus ovalis here, we call it limbus ovalis or annulus ovalis. This one, the lower edge of the septum secundum, and of course the floor that you usually put your finger on it when I ask you indicate foramen ovale. Of course you would certainly touch the floor of fossa ovalis, represents the septum primum. You need to remember this flap here. This flap is made by septum primum, and as the pressure increases inside the left atrium with the first respiration that the newly born baby or infant takes, the pressure increases, the flap moves against the wall, and it closes, forming what we later call fossa ovalis. The floor is made by septum primum. The edges around it are remnant of septum secundum, and we call them annulus ovalis. If you to try it during a practical session, it would be thick, the annulus ovalis. So the blood was sneaking between these two structures as the pressure is greater in the right atrium from the right to the left, and then from the left the pressure in the left side after birth would grow and pressurize the wall, the flap of the septum primum to close. This is the genius design that I talked about. Now we have we have maintained the blood supply, the blood flow from the right atrium to the left atrium through foramen primum, then through foramen secundum. Then we've built a wall we built a wall, and we redesigned the first wall. So after birth, these walls would come in contact and they would close off the foramen. What a genius design that we have witnessed in this lecture. Now let's go to the ventricles. The separation between the ventricles is not complicated in terms of blood flow. We don't for after birth we don't need the ventricles to communicate. But inside the embryo, we don't have these challenges because the blood is not coming to the right ventricle, and we don't need it to take it from the right ventricle towards the left ventricle. So what we discussed in the atria shouldn't and wouldn't be as much evident. No, still we need to separate the right ventricle from the left ventricle for the sake of afterbirth life. Now, the ventricular septum begins its development as a projection from the base of the inferior wall of the ventricle. In the atria, it was from the cranial. Here, it was from the floor, and towards again the septum intermedium. As it enlarges, the septum, we mean the ventricular septum, forms two horns which reach up to the corresponding atrioventricular endocardial cushions, or what we call septum intermedium. You may find endocardial cushions as the events of septation is simultaneously at the same time. We building septum primum, and we building the ventricular septum. We building the interatrial septum. Now, if we take the ventricular septum, it would look like this. Coming here, this is the inferior part. It has upper and lower horns, leaving this foramen. And of course, now you are an expert, you know what we're gonna call this foramen. It is the primary interventricular foramen, as it separates between the two ventricles. Our aim for this ventricular septum to reach the endocardinal cushions, or what we're gonna call later on septum primum. So on between the atria, at the same time we are building interatrial septum in the way we just discussed, and in the ventricles we are building the ventricular septum in a very simple manner. The upper crescentic border of the septum bounds a temporary connection between the two ventricles, as you can see, called the interventricular foramen. The ventricular septum forms the muscular part. So this ventricular septum that began to grow from inferior towards the septum intermedium, we call it, and all what it made, this part is the ventricular septum, forms the muscular part of the interventricular septum. And we did mention that in our practical sessions, that the ventricular septum has two parts. The anterior 2/3 are muscular, and the posterior 1/3 is membranous. Now, until the 7th week, there is a crescent-shaped opening, interventricular foramen, between the free edge of the interventricular septum and the fused endocardial cushions. So we are talking about this septum, ventricular septum, and foramen or septum intermedium, or the endocardial cushions. So the blood is communicating between the right ventricle and the left ventricle. The interventricular foramen permits communication between the right and left ventricles. At the end of the 7th week, a downward extension occurs from the right margins of the atrioventricular endocardial cushion, septum intermedium, that would be formed by now to close the interventricular foramen. This extension forms the membranous part. So this here, the muscular part of the interventricular septum. Now, between the endocardial cushions and the newly formed muscular part of the ventricular septum, an extension from the endocardial cushions, which are named now septum intermedium. They would extend to meet this part, and they form the membranous part. Now the membranous part in fact is more complicated than this. The so when we talk about the interventricular foramen, so this one here, the whole area here was interventricular foramen. This here is the muscular part. We know it is an outgrowth from the inferior wall of the ventricle, going up with its upper horn and lower horn, approaching the endocardial cushions. Now, as they do so, the endocardial cushions participate in the closure of interventricular foramen, and by contributing towards the membranous part. But this is not enough. The foramen is almost superior in this wall, and therefore an extension from this area, the proximal bulbar septum. We didn't talk about this. Don't you ever forget that we have separated the atria. We are separating the ventricles, but you just need to remind yourself that we are talking about a coiling tube. The ventricles are continuous with bulbus cordis and with, this is bulbus cordis, and with truncus arteriosus. Now we need also this septation between the ventricles to continue. We need we need the pulmonary trunk to exit from the right ventricle, and we need the ascending aorta to exit from the left ventricle. And therefore our story is to be continued maybe in the next lecture. But here the bulbar, it means from bulbus cordis, the septum inside bulbus cordis, we call it bulbar septum. Okay, they come and they participate in the closure of the ventricular septum, and therefore as you can see, the ventricular septum has three components: muscular, and the membranous, which is made by the endocardial cushions, and the proximal bulbar septum. Three distinct structures contribute to the formation of the postnatal ventricular septum. The muscular ventricular, we said that. Then of course the proximal parts of the outflow cushions, the spiral septum or proximal bulbar septum, and the endocardial cushions. And therefore membranous septal defects are the most common. It is a common rule in embryology. Whenever we talk about any structure that is made out of the union of more than two structures, the possibility that some of them wouldn't meet the other is higher than when we talk about two structures meeting each other to form one another new structure. So that's why membranous septal defects are the most common heart defect. 25 of all congenital heart defects, partially because three basic primordia, interventricular septum, spiral septum, endocardial cushion, are required to fuse in an area of a very dynamic blood flow. There is considerable opportunity for a failure of fusion of these elements at the location of the membranous interventricular septum. Now postnatal shunts, right to left shunts are cyanotic, and left to right shunts are non-cyanotic. We are talking about the appearance of the newly born babies, and we have to get this concept of cyanosis and when it takes place. Right to left shunts are cyanotic. This means when the blood coming from the right chambers to the left chambers, the outcome is cyanosis. Now, from the left to right shunts, the oxygenated blood going towards the non-oxygenated, the outcome is non-cyanotic conditions. And therefore now we will talk about the ASD, atrial septal defects, and then we would talk about VSD, ventricular septal defect. The atrial septal defects is one of several congenital heart defects. It is more common in female births than in male. Postnatally, ASDs result in left to right shunting and are non-cyanotic. After birth, the pressure in the left atrium, left ventricle is more than the pressure in the right and left atrium. So if we have a postnatal ASD, the shunt would be from the left to right, and it is non-cyanotic. What does this mean? You will not notice nothing is on the external appearance of the baby to alarm you that there is an opening left between the atria and between the two atria. Two clinically important ASDs are the secundum and primum type. The secundum type ASD is the most common ASD. It is caused by either an excessive resorption of the septum secundum or an underdevelopment and reduced size of septum secundum, or both. And it would be on the superior part of the interatrial septum, and usually it is large in size. So either the septum secundum did not cover this, did not grow very well, or of course, septum resorption of the septum secundum was excessive. Both of them would lead to the same point. This ASD results in variable openings between the right and left atria and the central part of the atrial septum above the limbus. It is above the limbus, and this is very important. If the ASD is small, clinical symptoms may be delayed as late as age of 30, so the size plays very important role here. In about 20% of cases, fusion of the septum primum and the septum secundum is incomplete, as we mentioned, with the pressure in the left atrium increasing after birth. Both septa should come together and close. Sometimes in 20% of people an oblique cleft remains between the two atria. This condition is called propatency of the ovale foramen. It does not allow intercardiac shunting of blood, so it wouldn't harm the patient himself. Ventricular septal defect. It is the most common of the congenital heart defects, being more common in males than in females. So ASDs are common in females, VSDs are common in males, being more common in males. The most common VSD is membranous, of course. Ventricular septal defect associated with the failure of neural crest cells to migrate. Now, we have to stress on this. I did mention that the endocardial cushions that participate in the formation of the membranous ventricular septum and the bulbar septum, so the endocardial, the bulbar, all of them they are associated with the migration of neural crest. they are not originating from the heart itself, but rather they migrating and settle down in the heart. And therefore, if anything arrests their migration and development, we would have, of course, defects. And therefore, the most important defect here is the membranous defect. As I told you, two endocardial cushions and bulbar septum participate in its formation, and then they have to meet with the ventricular muscular part. So that's why VSDs are more common to take place, and they are more common in males than females, and they are related to neural crest migration. VSD, it results in left to right shunting. So again, ASDs, they are left to right shunting. Now what is here? It is left to right shunting of blood through the AV foramen. So the same what is true for the ASDs, it is true for VSDs. The pressure between the left atrium and the right atrium, the pressure is higher in the left atrium. The pressure between the left and right ventricles, the pressure is higher in the left ventricle. So the blood would shunt from the left ventricle towards the right ventricle, and the result is non-cyanotic appearance. So also immediately you wouldn't see any changes on the skin of the baby as the mixing is coming from the oxygenated toward non-oxygenated. But causes increased blood flow and pressure to the lungs, pulmonary hypertension. Pulmonary hypertension causes marked proliferation of tunica intima and media of the pulmonary muscular arteries and arterioles. I have to explain this to you. Though the cyanosis is not taking place, the blood, the oxygenated coming from the left ventricle going towards the right ventricle, okay, but with time, the blood amount inside the right ventricle is getting more and more, and the pressure here on the right ventricle is building up. It also pumping the blood towards the pulmonary artery and its branches inside the lung, and the pressure there is increased, and the unique structure of the pulmonary arteries would be changed, and of course the pulmonary resistance becomes higher than systematic resistance. So the pulmonary resistance is growing up, and it would overcome the systematic pressure and causes right to left shunting of blood and late cyanosis. So there would not be early cyanosis after birth, but as the condition left untreated, the pressure inside the lungs would of course build up, and it would resist and it would overcome the systematic pressure, and of course the shunt would change from the left to right. It would become from the right to left, and the non-oxygenated blood would go through the systematic blood, reaching the skin and causing, of course, cyanosis. At this stage, the condition is called, of course, Isminger complex, and this complex is very important, maybe in the future for you to understand. So as you can see, the ASDs and VSDs are shunting blood from the left chambers towards the right chambers, and they are non-cyanotic. This is what important. And of course, the ventricular VSD should be highlighted as it passes through two periods: the non-cyanotic, which is early from the right, from the left, the shunting from the left ventricle toward the right ventricle, and of course later, if the condition is not treated, the shunt would become from right to left, as the pressure in the pulmonary system overcomes that of the systematic pressure inside the right ventricle. And of course the shunting would change the clinical manifestation, where we would notice, of course, cyanosis. So the whole lecture I would discuss with you all these events. We would summarize them in very simple points.